Now, our next speaker is Matt Rawlins, who is a senior pharmacist, antimicrobial stewardship and infectious diseases at Fiona Stanley Hospital, Western Australia. Matt's had a lot of experience in a lot of things, and it's always great to hear him talk. And he's going to tell us today about subcutaneous antimicrobial therapy and tell us about some of the local experience. We can see your slides there, Matt, so whenever you're ready.
Okay, thanks very much, Ben and Jason and the organising committee for having me. It's a great honour. So I'm based at Fiona Stanley Hospital in Western Australia, for those of you who don't know Australia. So we're in the isolated bit on the west, and we are the sort of main quaternary transplant hospital over here in the Perth metropolitan area. So I'm going to just run through our experience in administering antimicrobials subcutaneously, and particularly with reference to our OPAT, or as we call it, IDAC, Infectious Diseases Ambulatory Care Service from our hospital. So subcutaneous antimicrobials are a common practice in France, and most of the data comes from there. And generally, the agents selected are time-dependent killing antibiotics, so beta-lactams, and there is also some experience with teicoplanin, which obviously is more related to AUC killing. It's often used in patients who are too difficult to, or who are difficult to cannulate intravenously, and it's a bit unkind to give intramuscular dosing to, so the elderly, possibly palliative care patients. So I'm going to run through how we set up things at FSH, if you like, in preparation for its primary use in the OPAT setting, and then give a couple of conclusions as to what we like and what to watch out for in terms of if you're planning to do it at your own service. So most data, as I mentioned previously, does come from France, and it's primarily with ceftriaxone and then ertapenem, followed by teicoplanin. And there's been a number of studies in the French setting which have concluded that it's reasonable to use subcutaneous administration in non-severe infections or where other routes are not feasible or desirable. Interestingly, I believe the background to this is that subcutaneous administration used to appear in the ceftriaxone PI. I'm not sure if it was the Rocephin brand or another, but it was removed in 2014, and that's why actually ceftriaxone is the most commonly administered antimicrobial by that route. The French agency, at the behest of the EMA, actually removed the recommendation of the subcutaneous route in 2019, suggesting that it shouldn't be performed at all. However, the French Infectious Diseases Society are of the opinion that really it should be a risk-benefit assessment of patients, and that ceftriaxone may still be favourable for some patients, and that subcutaneous administration should not be banned. So generally, there's two preferred sites for subcutaneous infusion, and it's normally the lateral abdominal wall or lateral thigh. We use the abdominal wall. Infusion should be given prolonged, so a minimum of 30 minutes and up to, say, 60 minutes. These butterfly needles can stay in for up to 7 days, but the recommendation is to rotate the infusion site every 3 or 4 days, or immediately if there's local inflammation, to reduce local reactions, and along with daily clinical surveillance of the subcutaneous infusion site. Non-rigid catheters avoiding metal between 20 and 27 gauge should be employed to reduce local irritation. And interestingly, the recommendation is actually to preferably dilute in normal saline because it's associated with less local adverse effects than glucose 5%. So if we move to, firstly, to look at ceftriaxone, the usual dose that's given is 1 gram over by a subcut infusion once a day. However, other doses ranging from 0.5 to 2 grams have been employed. And when PK studies have suggested that the AUC and the time above MIC is generally very similar between subcutaneous and intravenous administration. The main feature, which obviously supports time-dependent killing antibiotic, is generally you get lower Cmaxes, so lower peaks, and a slower time to achieve your peak concentrations. So, but generally this data is all obtained from healthy volunteers in terms of the PK studies. The sort of indications which have been employed have been ranged from UTI to respiratory tract infection, bone and joint infections, and intra-abdominal infection. Durations described clinically have been between a week up to 2 months. And in a recent review, which was somewhat systematic, there were 51 local adverse events described of 8,500 administrations. So it's pretty well tolerated. There was 1 report of skin necrosis, and that was associated with the larger 2 gram dose. And interestingly, they actually suggest that to monitor for neurological toxicity, so encephalopathy and abnormal movements. But certainly I've not seen that with ceftriaxone intravenously. So I thought that was of interest. Moving on to ertapenem. So the doses are again, typically what you'd expect, 500 milligrams, usually in the context of renal impairment, up to 1 gram over 24 hours, although, or per 24 hours, I should say, not over 24 hours. One study, interestingly, gave extremely prolonged durations of therapy of 1 gram 12 hourly for bone and joint infections, which were for basically non-curable bone and joint infections. So that's certainly a higher dose than I'm used to using. In terms of the bioavailability, again, very similar AUC, lower peaks, longer time to peaks, higher C-mins, so trough levels have been reported, and longer half-life. So really you're enhancing your time above MIC, which is clearly a benefit for time-dependent killing antibiotics. Indications, UTI, bone and joint infection, intra-abdominal infection, the sort of things you would expect. We primarily use it for urinary tract infections for ESBLs where there's no oral options. In terms of administration, the methods described have been, again, abdominal wall or lateral thigh over 30 or 30 to 60 minutes. There's also been a subcutaneous injection, a push described, often combined with lignocaine, and that's given over 1 minute. Duration, again, can be extremely prolonged. A 90-day mean, one study reported using 90-day mean duration for bone and joint infection. One thing that really, and this has caught us out as well, particularly with rapid discharges, neurotoxicity, and it's extremely important, as it is with IV therapy with ertapenem, to adjust the dose for renal function. And so using a 500 milligram dose for those with a decreased creatinine clearance is indicated. From the literature, there were 7 cases of local adverse effects out of 224 patients. And one of these reported necrosis, but it was in the setting of the IV push, and there was lignocaine in there. It's remarkably well tolerated in our experience. The third agent, which has a significant amount of data, is ticaplanin. And interestingly, the French experience suggests that you should try to load with intravenous therapy, if able, and then go to subcutaneously administration for maintenance dosing once daily. This is on the basis of one study which suggested that in the first 48 hours, the trough levels and the AUC was lower with subcutaneous administration compared with intravenous administration. And so this is their recommendation. I have to say, we have normally, it really depends. It's more a pragmatic approach from our point of view. I think if a patient has been commenced on ticaplanin and the subcutaneous route is considered to be something we're considering for going home, they may well have been loaded on IV anyway. Otherwise, if we're looking for a quick discharge of the patient, then subcutaneous loading has not appeared to adversely affect our small numbers of ticaplanin patients. They also report that doses below 600 milligrams or 600 milligrams or below, when given subcutaneously, are better tolerated than higher than the, say, 800 milligrams. Well, our maximum is 800, as I've mentioned. And it's also suggested to improve tolerability to give larger doses over a slower period of time. Indications, bone and joint infection, and they have actually used it for infective endocarditis too. TDM is recommended weekly, and more local adverse events have been reported, up to 70% in one study. However, no skin necrosis, and obviously the recommendation is to do regular therapeutic drug monitoring. So there are some other antimicrobials for which some data exists. Ceftazidime is felt that to be something that would be quite amenable to subcutaneous administration. However, ordinarily it's going to require at least BD or 3 times a day dosing. There is some clinical experience with it, and it was well tolerated. Ampicillin has been used in healthy volunteers only. Cefepime, there has been used in a few patients with bone and joint infection. Again, I think if you're needing to administer it 3 times a day, it may well defeat the purpose of using subcutaneous route in the hospital and the home. Pip/Tazo has been used in hospitalized patients. Aminoglycosides have kind of got a bad name, but it's mainly related to old data. Obviously, if you're giving an antibiotic and via subcutaneously, and you're getting a lower Cmax, and it's a concentration-dependent killing antibiotic, well, that's a disadvantage from a PK point of view. Plus, there have been reports of skin necrosis associated with aminoglycosides. So it's pretty much recommended against. Other agents which have been assessed or are under clinical trials are metronidazole, daptomycin, which could be quite interesting for the OPAT setting, and augmentin. And also, we've got a bit of data which I'll mention just briefly at the end on benzathine penicillin in the context of prophylaxis or secondary prophylaxis for rheumatic heart disease and possibly treatment of syphilis. So we, in order to start using this here, we at FSH we submitted an evidence-based proposal to use these 3 antimicrobials by subcutaneous infusion, and we were required to notify patients over a 3-month period to the Drug and Therapeutics Committee. So primarily it was ertapenem, a handful of teicoplanin and 1 ceftriaxone. Interestingly, we did some TDM on the teicoplanin, on 2 of the teicoplanin patients, and you can see you get really quite good exposure. One person 7 days into their treatment, an 86-year-old man, had a trough level of 35, and then a 75-year-old who had a PICC line infection. Therefore, that was removed. There was no IV access, and we, 16 days into treatment, 20 heavily immunocompromised patient had a trough level of 23. So really quite good exposure, and certainly no concerns about inadequate levels being attained. So our administration is via the route that's been prescribed by Frasca et al. From 2010. So 50 mils of saline administered through a butterfly needle placed into the subcutaneous tissues of the lateral abdominal wall, 24 gauge, and over 30 to 60 minutes. And this is the butterfly needle in question. So Rawlins, Manning, this group published on the FSH OPAT experience, where we compared outcomes for IV versus subcutaneous ertapenem. We don't have local TDM available. We're not in the fortuitous position of Jason. So it was over a sort of a 2.5-year period, comparing 81 IV with 22 subcut ertapenems. As I said before, mostly for ESBL UTIs with no suitable oral options. Interestingly, the subcutaneous group were more likely to have CKD, and the median duration of therapy was around 14 days for both groups, and similar median OPAT duration. So most people got it for a couple of days before they went out. Cure rates were very similar. In terms of complications, well, there was a PICC infection in the IV group. One feature of subcutaneous administration seems to be that it's just a complete absence of line infections in the literature, and certainly in our experience too. We had 1 neurotoxicity and 1 neutropenia in the subcutaneous group. There was no skin necrosis, and really it was noted to be a good vein sparing technique in patients with CKD, and even one of our patients had CNS toxicity, and really dose reduction is key, or dose assessment is key for these patients. So we've got a subcutaneous antibiotic guideline specifying how to do it, making sure that the lateral abdominal wall is free of irritation and that might be enhanced, if you like, by subcut butterfly needles being in situ. And we put in our 3 product monographs for IV administration, we put a statement. So this is for the ertapenem one, maybe administered subcutaneously if the IV route is not available, on ID physician recommendation only. So then IV administration guidelines all include subcut administration, and we give a directions which are essentially the same as if you were going to give a IV infusion. So ertapenem 500 or 1 gram, tyco up to 800, and ceftriaxone we only recommend a maximum of 1 gram, and that's based on that really single episode of from the literature of a 2 gram necrosis occurring. We've had further FSH OPAT experience. So in the last sort of 18 months, we've used more than 30 treatment courses of ertapenem. Neurotoxicity has occurred again, and this was mainly in the context of trying to ensure rapid discharge. Patients were often didn't have, to my mind, a full pharmacist review of dosing, and as a result, there were a couple of falls which occurred before the patient actually left the institution, and then a couple more subsequently. And we've had a handful of teicoplanin and ceftriaxone more patients each. It's essentially well tolerated, and it expedites discharge. So as I mentioned, Lawrence Manning has been investigating benzathine penicillin being given subcutaneously. And the idea is you load up the with around 3 times the dose, or maybe even more, into a subcutaneous infusion, and you have the potential to administer only every 3 months. There's obviously a potential use in syphilis. They've been trialling it in children in New Zealand for secondary prophylaxis of rheumatic heart disease. And he said, his comment to me was, it is scarily well tolerated. It's been better tolerated than he ever thought. And obviously reducing the frequency of injections is of great benefit to children. So in conclusion, our subcut antibiotics they're very well tolerated. They appear to have good exposure with good clinical, and as well as a couple of patients with therapeutic drug monitoring have proved that we get good exposure. It's convenient. It's vein sparing, particularly in patients where access is difficult. And you don't have to wait around for people to insert intravenous lines. We also have a DIVA, difficult IV access service, waiting for PICC lines. It facilitates discharge. In terms of negatives, really the big negative was people got a bit freaked out. So this ranges from doctors, nursing. I'm sure many of you are aware we actually, Silver Chain are contracted to provide our OPAT service for metropolitan patients, and they were very concerned when they first came across this. But as soon as we put it in the IV guidelines and said it's exactly the same, except you're just giving it via exactly the same preparation, exactly the same administration, you're just giving it via a subcutaneous butterfly, they were happy. And I would say in the rush to discharge patients, don't forget to dose adjust according to the patient in front of you. And of course, there were no line infections as well. So thanks very much for having me, and I'll hang around for questions later.
Fantastic. Thanks so much. Pardon me. Thanks so much, Matt. I've asked you a lot of questions about that previously, and I've still got more to ask when we get to the Q&A session at the end.